Um, what can we do to make a difference? We saw that COVID really laid open and exposed all of these injustices that have been going on for a long time. And I'm sure everybody that's here in this webinar knows that that's what's been happening, but it laid it open for the public, and the stress of the COVID pandemic really exposed this. So as we are hoping to think about going through recovery, getting back to normal is not the way to go. We have to go beyond that. And we want to explore what can be done to create an inclusive society, a society where everybody is included, where there is no oppression and injustice and people are living well. So that's what we're hoping to do with this webinar series. We want to share what we've learned, what we've experienced, what's been happening, and look at, well, why has this been happening? And now what can we do, or what strategies could we put in place so that we're building a better society? And this evening, we are looking at particularly around the social and the fiscal policies that have had negative impacts on particular populations, various populations. We have a group of people here this evening with a great deal of experience that are going to share their knowledge and understanding of what's been happening. We want to make this as participatory as possible. I'm a facilitator, used to being in a classroom, so trying to figure out how to do this on the web. What we're going to do is people are going to share their knowledge and experience and about what has been going on, what is happening. And then we want to get some input from you, the participants. What are some of the things that you see? What is happening in your community? What is your experience that you're seeing? Then I hope to go on to, well, looking at why this is the case. Why is this happening the way it is? And I will go back to the speakers then to help us understand that, and then as well get your input. And then we need to get to, okay, so now what are we going to do about this? What does this all mean? What are the sorts of strategies that we need to put in place? This is the first in a series of webinar series. So we're going to be setting the stage this evening, and then again in the future there will be others to look at other aspects of these policies and so forth that have had such negative impacts on so many people in our province, and people of different colors, different groups. So we're really hoping to come together and learn and see what we can do to make a difference. So for this evening, I'm very happy to have some very distinguished and experienced people who are going to share with us their knowledge. We're going to begin with Monika Dutt. And Monika is a settler on Unama'ki, and she is the daughter of immigrant parents and mother to a 9-year-old. She is a public health medicine specialist and a family doctor at the Alley Center of Cape Breton. She is also part of the Canadian Doctors for Medicare, the Cape Breton YMCA board, and the Decent Work and Health Network. So Monika will share her experience and knowledge in terms of looking at the framework of how we're going to look at all of these issues through a lens, a framework of anti-oppression and social justice, social inclusion, to help us look at all of the different aspects of this series. After Monika, Christine is also going to share her experiences. This is Christine Saulnier, and she is the Nova Scotia director of the Canadian Centre for Policy Alternatives. She has a doctorate in political science from York University. She leads the living wage calculations for communities in Atlantic Canada and has served as a co-author for the annual Child and Family Poverty Report Cards for Nova Scotia. She is a frequent media commentator on fiscal policy, minimum wage policy, and a range of social policies, including childcare, income, and income assistance. So she's going to be sharing her thoughts around policies, social policies, and how they've had negative impacts. And then we're going to hear from 3 people who have experience on the ground and working with organizations. Sherry Costa. And Sherry is a proud Nova Scotian that she has been part of the disability community for more than 40 years and currently manages the Nova Scotia League for Equal Opportunities. Prior to this, she served on the League's board for 14 years. She holds a certificate in nonprofit leadership and management from Dalhousie University, earned while serving as executive director for Independent Living Nova Scotia. Sherry also led the development of Voice Print, now Accessible Media Inc., AMI, in the Atlantic region, chaired the Partnership for Access Awareness Nova Scotia, PANS, committee for 7 years, and was a member of the Nova Scotia Persons with Disability Employability Table. Sherry is also a founding member of Nova Scotia Disability Partnerships and Federation of Community Organization. Her experience and background offers insight to the challenges and opportunities. We also have with us Afolake. Awoyiga is a clinical, I'm sorry if I didn't get that right, Afolake, is a clinical social worker with the experience in community development and working with immigrants and other marginalized populations. Her most recent experience has been working at the IWK Children's Health Center as a part-time sessional instructor at the Dalhousie School of Social Work. Afolake is a co-founder of Generation One Leadership Initiative, a support and educational group for youth and families of African descent. She previously worked as a healthcare social worker with the Nova Scotia Health Authority and as a child protection worker with the Department of Community Services. And this will be followed by Kristen Basque, who is a Mi'kmaq social worker from Eskasoni First Nations, Nova Scotia. She was born and raised in Eskasoni. Kristen is the supervisor of Wigame Manik Gigmaknak Family Group Conferencing Program, where she continues this role to promote building positive relationships, reconciliation, and healing while empowering families to make decisions for themselves. Kristen resides in Eskasoni with her partner Bertram and their 12-year-old daughter and 8-year-old son. She is a fluent Mi'kmaq speaker and believes in the importance of preserving her language and culture through embracing culturally relevant practices with families in their own communities. So you see that we have quite an experienced lineup this evening that is going to share their knowledge and experience. And we're going to start with Monika, who will give us that overview and framework. Thank you.
Okay, so I'm going to share my screen. So far, everything's going smoothly. Except then I realized I can't see my notes. That's not going to work. So I'm just going to do, sorry about this. I didn't think of that. I'm just opening up my email because I have my notes there. And then you don't have to look at that. There we go. So thank you very much for having me here today. I'm really glad to be part of this group, and I'm looking forward to hearing others speak. It's nice to be able to start things off, but I think there's a wealth of experience both within the people who are presenting as well as in the audience. So I hope we'll have a chance to have a good discussion. So usually in kind of physician type presentations, we always have to state our conflicts of interest. And I've started using this type of a framework, kind of stating where I'm coming from. And it's a wheel of power and privilege, and kind of situating myself in many ways in the kind of the center of this wheel, with the roles that I hold in terms of being a physician, able-bodied, and a number of different factors there. But like all of us, we have different identities. And so there are some aspects that give me less privilege from skin color and other aspects. But on the whole, I typically have that power that comes with being a physician and also being part of institutions that often both can be quite helpful, but also are based in the colonial and racist history that we have in this country. So I just wanted to start with that as my starting point. And what I wanted to do today is think about how, as we are putting together policies and we're doing work within the pandemic as well as going forward, how we can adopt and implement an anti-oppression lens to the work that we're doing. And I think a lot of the practicalities of that are going to come out through the evening tonight. I put this slide up as a quote that or not a quote, a statement that I've thought about a lot since she posted it. It's she is a physician colleague, Dr. Lisa Richardson, who's in Toronto, and she is a mixed Anishinaabe woman, is how she describes herself, and also an internal medicine specialist and the vice chair of culture and inclusion at the University of Toronto. And so she talks about how when you invite someone or you are speaking at a panel or media, to be thinking about, whose voice have I chosen to amplify, either in the people you're inviting or the place that you're speaking. And so today I was thinking about, well, I guess as I put together the last few days, thinking about kind of two particular voices that have kind of stuck with me from the beginning of the pandemic, and then one a more recent story that I've been thinking about quite a lot. And the first one is this young man, a 17-year-old, whose name is Lemo Mohammed. And he was someone who, back near to the beginning of the pandemic in April, he lost his mother to COVID-19, and she was 44 years old. Her name was Bontu Abdullahi. And he lives in a part of Toronto that now, if you've been following the news and they've talked about what parts of Toronto are harder hit by COVID-19, he lives in an area that has systemically been neglected through lack of proper housing, through structural poverty, through a number of different historical and current reasons have made these areas of Toronto more susceptible to COVID-19. And his mother was a personal support worker. And we also know that personal support workers are typically low paid, they're typically in precarious work situations, and they do work that is often done by racialized women. And so when I read about his story and thought about his mother, it just seemed like, as was said a bit earlier, that all the injustices that have always existed for many years are, they're not new. It's not something that COVID-19 has necessarily shown us. They continue to exist, and they very sadly have come out in his story. And the other story I've been thinking about, which is more recent, and I know both of these stories might have personal difficult connections with people, but it's the story of Joyce Echaquan, which I hope people know of her story, a 37-year-old woman who is Indigenous, and she lived in Quebec with her 7 children. She went to a hospital, Joliet Hospital, and live streamed her last time in her life as nurses and healthcare workers were saying terrible, racist, horrible things to her, and she died not long after that. And there's been a mix of reactions from people who have various abilities to change these types of situations, either referring to it as systemic racism or, as often happens, talking about individual actions. But to me, both of these stories very much get to both the individual actions that people take as well as the systemic issues that we need to deal with, because any individual action has layers of support that have led to somebody thinking those types of actions are okay, or those types of policies are acceptable. And so I think of both of these people as I speak tonight. And so what I wanted to talk about is how we can integrate an anti-oppression lens into the policy work that we are all doing or advocating for, or trying to support and to have put into place. And so first, kind of thinking about what does that mean in this is a very short time, I just in these first few minutes, but to me, one of the main things it means is to shift the way we think about policy making. And so I work in health. I work both as a medical officer of health, not in Nova Scotia, as well as a family physician. And my framing is how can we all be healthy, and healthy in a very broad sense? How can we have well-being? How can we, have a community that we're comfortable in, have, a life that feels decent? And so we often talk about social determinants of health, which are things like access to education, to income, to housing, and all of those are incredibly vital. But we also need to look deeper than that. We need to move from social determinants of health to thinking about structural causes of health inequity. So if someone doesn't have access to that housing or income, why is that, and why is it happening, and why should we consider these to be health inequities? And I don't want you to have to read all the words on the slide, but the blue headings on top of each one are talking about health inequities. So things that are systemic, avoidable, unfair, and unjust. To me, those are the main points to consider. So it's not the same as just looking at two different groups or individuals and saying one person's health or one group's health overall is better or worse than another group. We really need to look at why that is and know that it is avoidable and it is unjust and unfair, and look at how we can change that. And so as one example, you could look at any of the determinants of health, but I took this one resource that speaks to racialized inequities in particular. So starting at the bottom, if you see a difference in health outcomes between two racial groups, knowing that those racialized inequities are contributed to by all these other factors. And so going through the different layers, it talks about white supremacy, it talks about our culture, our institutions. So we always need to look beyond why something is happening, or look beyond the numbers to look at why something is happening. So I think structures and frameworks like this really help us to be able to do that. And we can do that with kind of any determinant of health. So if we look at income, which we're talking about tonight, we can talk about structural poverty and why certain groups and people are much more likely to be poor than others. And it's not by accident. It is very deliberately through different policies that have been put into place that contribute to poverty. We can look at housing and see which groups have been systemically marginalized such that they are the ones that end up in precarious housing. We really need to look at Canada's history and the policies and the power structures that have made certain norms acceptable to many, especially those who have power, and made those policies be the way that they are right now. And those policies have embedded marginalization of different groups, and I'm only touching on a few in these few minutes, but looking at people of Indigenous background, Black folks, immigrants, racialized people, women, LGBTQ, religious minorities, people living in poverty, people with disabilities, and I know we could all list many more groups. And all of us also have multiple identities, so also recognizing that you may overlap, and many overlap between these different groups. And for example, in COVID-19, when I was speaking about personal support workers, when you look at certain data, say in Ontario, we know that there's been a disproportionate number of newcomers and immigrants who have been diagnosed with COVID-19. And when you look at just the healthcare workers, it is just disproportionately racialized women. So again, none of this is an accident. We have put people in these precarious situations, these higher risk situations, and we're seeing the result of that. So to be able to change that, we need to recognize that, almost all of the institutions that we are part of or we work in are part of, either changing these structures or keeping them in place. And we all have work to do to be able to change that. And it takes explicit and intentional work to be able to do that. And so in terms of how we do that, that was going to be my example. So I'll get to that in a minute. But in terms of how we do that, I was I know this would be a diverse crowd, so it would be hard to kind of say for each person in each organization how to go about doing that. But I was thinking about in particular for the field that I'm in. So thinking about how we can look at the place that we have and the institutions and organizations we're part of and break that down and look at how we can then apply an anti-oppression lens to our own organizations as well as the work that we do. So thinking of, public health, which is where I spend most of my time. And, most of the time I like to think of public health as trying to improve the health of communities and generally doing good work. But at the same time, it doesn't take away the fact that public health has a history of doing things like when you think of tuberculosis in Indigenous communities and how we were part of, ripping families apart and having people taken from their communities, put into segregated hospitals, given poor health care, often dying and not having that contact with their families and families not knowing where they had gone. We can't ignore that we've been part of things like this Tuskegee experiment in the US when we explicitly recruited Black men who had syphilis, denied them treatment, and just followed the course of their disease purely to see what happened with the disease. And even now, I work in public health, and I recognize, there have been a lot of legal tools that have been used by public health, and I've seen and I know how they are often disproportionately affecting certain groups. If you don't have a house to be able to isolate in, if you don't have access to be able to, wash your hands and to take the precautions that we're advising people do, there is implications for public health now in terms of how we are enacting policies that disproportionately affect some groups. And so I thought I'd just finish by talking about a specific example, because I think this has all been kind of theoretical, and think about how that can apply in one specific situation that's related to COVID-19. And I was going to use the example of race-based data, which probably a lot of you have heard about or thought about or perhaps even been involved in advocating for. And it's this idea that we collect data that allows us to properly analyze the racial background of different aspects of COVID-19, whether that's, who's at higher risk, who contracts COVID-19, and having that data be available, because it is not something that we routinely collect in Canada. It's something that's often been done in the US and not as much in Canada. And I tend to think that it's incredibly important because it allows us to both quantify the impacts of, in this case, COVID-19, and allows us to be able to look at policies, and if we make changes, to be able to see what the impact might be, and hopefully to improve on the data that, or the information that we're getting. But at the same time, I think it's also a challenging topic, because as much as I think it absolutely needs to happen, I think it's a very complicated topic in that there are also many people, in particular ones whose data may be collected and may be shown to have those disparities, people often saying that, we don't want that data collected. And that could be for a range of reasons. It could be related to how data has often been used to harm instead of help people. So if you're part of a community that was, that's routinely under surveillance, that's routinely having data collected about you, that may have that data used in a way to make poor decisions that will actually harm you as opposed to help you, it's perfectly understandable that you might not want that data be collected. I think data ownership is a really important piece of this too. Who owns the data, who has access to the data, who's using the data. I think that's also really important. I think also the fact that it's about collecting data on race, but it's not necessarily getting at racism, which is the root cause of why we might see these differences related to race. So I think any issue is going to have those nuances to it. Anytime we want to take an anti-oppression lens, I think there's never going to be one right answer, but I think that needs to be worked through, and that's part of the process. And I think it's better to try to have those conversations and to engage people and to work with people to find the best way rather than not doing it at all. So in terms of kind of what that means for policy making, I think about it in a few different categories, and I just kind of put these together as some initial thoughts. And I know we're going to get into specific policies that can be put into place. But I think about it in terms of, what does that mean to us personally? And I know some of us have more work to do than others, but I think it's a constant, learning and unlearning that we all need to be doing. And then I think we need to look at our own workplaces and organizations. And I usually think of that in terms of what can we do internally, because there's usually quite a lot that needs to be done within an organization with our own, processes, with, diversity diversity moving to representation, rather than just checking off boxes to have really meaningful representation in an organization. We need to understand the roots of our own organizations and our own backgrounds and how that influences the work we're doing now. And we really need to have meaningful community engagement and taking leadership from communities. And then there's the external side, so the policies that we're advocating for, making sure that those are, again, community guided, that are building on the work that many have already done, and giving their voices to, whether it's the Truth and Reconciliation Commission or other processes that have really brought in the voices of many who have been negatively affected by historical colonialism, racism, and ableism, and many other kind of oppressive structures in our society. So I'm going to finish with that, because I know Christine is fantastic at taking data and turning it into really effective advocacy and policy making. And I'm looking forward to hearing her, as well as the others who are in this group. So I am going to turn this off, stop my sharing, and then.
Well, thank you so much, Monika. That was really good to help set the scene and the tone of how we're going to look at things. And as always, I love stories, and your stories really explained the need that we have to be vigilant and to do the analysis, to do the framework, to make sure that we are assessing what we're doing, that we're not causing with our policies, that we're not. It's an anti-oppressive lens, and I appreciate that. And you're right. Now, Christine is now going to talk about some of these policies and how they play out. So Christine, we'll move on to you.
Thank you. And thank you, Colleen. And thanks so much, Monika. That was a fantastic presentation. Really, really set the tone nicely for what's coming. And I'm excited to be on this panel with, I can't wait to hear the other people as well. I'm going to do what I was asked, and that is to give you some evidence, really zoning in on Nova Scotia about the impact of COVID and its mitigation strategies. And I am going to share my screen. See how this goes. Okay. So, good evening, everyone. And I am in Shabuktuk, the unceded, unsurrendered territory of the Mi'kmaq. And thank you, Colleen, for opening with remarks about us being treaty people and what's been happening in the territory, and how much more work we have to do. So I'm going to jump in, and I actually thought I'd just jump in. I mean, one of the messages from Monika's presentation is one that you will hear from mine, is that we need more disaggregated data. And with all of the cautions and precautions that Monika has outlined, we do need more data, not that we don't have enough for the government to have acted. And so I want to send both those messages to you. But in terms of COVID itself, I went back to the government site to see what we know about the impact of COVID, and this is what you can get. Now, there is only one other kind of disaggregation of the data from the site. So these are cases of COVID in Nova Scotia by age, by gender, and there's one other screen which I didn't copy in, which was geographic region. So you'll see that not surprising, and I'll say why. 61% of cases were women, 39% were men, 39% of cases were over 60. And I'll note that even on the data where you go to the website, it doesn't note how many were in long-term care, for example, and there's no race-based data, and there's no other data except percentage of cases. So you don't know in terms of those who died from COVID, nothing else. So this is what our government has given us. And I say I'm not surprised by the numbers about men and women because of some of the things that Monika also outlined, but also what we know about health. So women do tend to live longer than men, but they do tend to have more chronic diseases than men. And a majority of frontline service providers, so those who do what we'll call the 5 C's, so talking about, caring, clerical, catering, cashiering, cleaning occupations, those are women, and that they were more susceptible to contracting the disease. Otherwise, we don't have the race-based data. We don't know in terms of the economic region, that was not neighborhood level. So we can't say any more really about who was impacted directly by COVID. But what I'm really going to outline is really what Monika started with, the stories and with the data, which really tells us that the impact of COVID and the strategies to mitigate its spread, that impact was different depending on your situation in society, where you're situated within or in relation to different systems and structures. And so what was happening before COVID, so what Colleen actually started the webinar with, right? COVID didn't create the divisions, it merely, for some people, would have revealed them. For others who have been experiencing them, it would have exacerbated those. But what we can do, and what I will say, is despite not knowing what those race-based numbers are, as Monika also outlined, if you do look at Stats Canada's data, and they use visible minority as their marker for racialized workers, we do know that racialized workers are more represented in many of those jobs that I outlined. So likely, if there was some race-based data, we would see some overrepresentation in those numbers. And what about immigrants, refugees, and migrant workers? Again, very little data in terms of numbers, though absolutely people have been, and we will hear from people on the panel who are doing the frontline service and sharing the stories. In particular, I know there's been a lot of work done in terms of migrant workers and what's happening in our province. But we know that the migrant workers who are coming here, they've come here, and many of them are in unsafe working and crowded housing conditions. That their temporary migrant status means that they are more vulnerable, that they are less able to exercise their rights than other workers, and so they also are facing higher risk. So if we think about what we know about the systems and structures that were existing before COVID came, and I'm specifically thinking about Nova Scotia here, we can really extrapolate by looking at who was most vulnerable to living in poverty in our province. So again, thinking about what the mitigation strategies that we had to put in place in order to ensure that the disease wasn't spreading, but what impact did that have? What policies and procedures and public health directives, what impact did that have on the most vulnerable? So those living in poverty. And the slide in front of you does show that the groups that are more vulnerable to having higher poverty rates in our province are lone parents, Indigenous peoples, unattached, non-elderly, recent immigrants, people with disabilities, African Nova Scotians, women, almost no matter who they are, have higher poverty rates. Everybody on income assistance in this province, Those are the people who are the most vulnerable to living in poverty. So their poverty rates, and that's the slide I just put up there, will give you a sense of what I mean. So the 17.2, and the reason that this is not more recent is because, again, in order to get any data that disaggregates, we use the census. And so it's a little bit outdated now, but things certainly have not changed much in terms of the trends of poverty. The 17.2% is average poverty for Nova Scotia, and the other poverty rates are by different demographics. So you're looking at almost double for most of the groups that are outlined here. You'll note that these are StatsCan's terms, so Aboriginal identity off reserve. I don't have an on reserve number. So persons living alone is the very first one that you see on your screen at 35.6%. And again, the Nova Scotia average is 17.2. Lone parents at 35.7. Visible minority Black at 32. Recent immigrant, and I can't see the other one, persons with disabilities, is the last bar. And so if you look and consider what COVID maybe didn't teach some of us, but certainly taught some people, is again, the other group that we heard a lot about was the working poor. And we heard this in terms of retail workers, in terms of personal support workers and home care workers and long-term care workers, childcare, grocery store cashiers, the couriers, the warehouse workers. What we learned, in fact, is that a lot of people we pay the least are the ones we need the most, and the ones that we're putting themselves at risk during this pandemic. Colleen, I've forgotten to put a timer on, so could you note when there's a couple minutes of the 15?
Okay, well, you just say what you need to say, Christine, and we'll work it through. Okay, I've been enthralled with your talk. I haven't been paying attention myself. So.
Okay, well, you don't want to give me unlimited time, though. I want to hear from others. So, okay, I will keep an eye on the clock. So the fact that people are in such low-paid work often means that those workers were working at multiple jobs. They're often in temporary contracts, working multiple sites. We know again that increased not only their vulnerability, but ours. And what did our government do? What were the actions around ensuring that long-term care workers were able to only work at one site? How did we ensure that they then had compensation for the fact that they, were not working multiple jobs because they wanted to work multiple jobs and multiple job sites? It wasn't until May that the Nova Scotia government made an agreement with the federal government and announced that they would actually provide a temporary wage top-up for essential workers, noting that they, again, were putting their lives at stake. They were doing the essential work, most of them, doing all the mandated overtime. And, as one of the QP workers who's chair of their long-term care committee said of the raise, obviously a permanent raise would help alleviate chronic shortages and mandated overtime. And a living wage would make these careers more attractive. It would alleviate the need for many people to work two jobs to make ends meet. Those long-term care workers are amongst those earning $17 to $19 per hour, for which a permanent extra $2 an hour would make a big difference. They only got a pandemic premium. They have not received any permanent extra wages. And in fact, I don't think we've seen much change in terms of the long-term care situation in Nova Scotia. What we know, and of course the grocery store pandemic premium didn't last very long, and that's gone. So what we know in terms of the impact of what happened, we had a government that had to react. A pandemic is a health crisis that then created this economic crisis. This was not a recession. This was something very different. And so the waves that started with the layoffs, we saw a lot more women being laid off, a lot more women who lost a majority of their hours of work. And in terms of kind of understanding and unpacking what this means, when we consider that women were also now balancing their paid work with their unpaid caregiving, many of them were then, doing homeschooling at home on top of But many people, of course, went into the home and were doing work. So if it was possible, some work, of course, switched into the home. But there was no childcare available at all. And there were some good things about the fact that the government recognized that there were vulnerabilities in the childcare sector and they shut it down. But they also didn't provide essential childcare for anybody, not for the essential workers who were doing the work that needed to be done, who had children who needed care. And of course, what we also heard about women and the impact of COVID is that, and we know this by the research, is that the home is not always a place of safety. And so now everybody is suddenly being told to stay at home, and home, if you have one, isn't always the safest place to be. To be clear, you know, as we're in this, I don't know how, some kind of recovery from this complete shutdown, we look at what's happened. Low-wage workers have absolutely borne the brunt of the economic fallout. But, you know, you might hear this term, the K-shaped recovery. What that really means and what we have to underline is, you know, the higher your wage, the less likely it was that you lost any of your hours. The lower your wages, the more likely it was that you lost all or most of your hours. And now, the slower you are to regain those hours. In fact, what we've really seen is this gap growing where those who were struggling going into the pandemic are struggling even more now. They're increasing their debt. And those who were doing well are actually doing super well. Wow. So, you know, you have this gap growing. And I was looking at some polling that was released today, and it's quite startling. So 2 in 5 Canadians say they are worse off now, not being able to pay their bills, close to bankruptcy, only a couple $100 in savings. But 1 in 5 Canadians say they're better off than in this recovery. Like they are now better off than they were before. Mm-hmm. And, you know, we saw that with the owners of the grocery store that couldn't afford the $2 premium, but they've had record profit because things shifted, and we live in capitalism and there are markets that opened. And so there are some people, again, this is not a normal recession, that did very well while others are doing very badly. So again, if we look before the pandemic, many Nova Scotians were struggling to make ends meet. Here's our social safety net. So who was falling through as we were looking at thinking about what is needed to support people to ensure that they're able to follow the public health directives. Many Nova Scotians were uncertain about how to pay their next month's rent before the pandemic hit. Many were going without food or rationing because they didn't have enough in their food budget, or their food budget, of course, is their only discretionary money, and so they're using it to pay rent and keep the roof over their head. Mm-hmm. There was a tiny bit of, you know, people were not going to be evicted for not paying their rent just for a few months because there were actually no boards meeting, not because there was a real ban of eviction or a rent forgiveness program. Mm-hmm. Other Nova Scotians before the pandemic were not able to access, to have their healthcare needs met in a timely fashion. Now we did have one positive thing that came out. I think it was really the ability to have virtual doctor's visits. Now, that's only if, of course, you were fortunate enough to have a physician, right? Mm-hmm. And then, of course, many families were not able to access childcare. So, you know, we went into the pandemic with this kind of social safety net. And unsurprisingly, as I said in the beginning, those living on income assistance, what was the support they received? It was a $50 one-time payment. But and I know the chart in front of you is very busy. This is just to give you a sense. So if you are, let's say, a single parent with one child living in Halifax when COVID hit, and you were receiving social assistance, the Canada Child Benefit, maybe a little bit from the Affordable Living Tax Credit, the Poverty Reduction Credit, anything that you could get access to as a low-income family, you were still looking at a poverty gap. That means you were $8,000 below having what you need in order to just make ends meet. And that's for basics.
Okay.
$50 a month?
Christy?
Okay. That was your signal to me to stop talking. Okay, I will stop there, and I hope what and this is just information. Maybe what we'll do is I'll share the slide at some point, was to ensure that people understand and underline why it was so important that the policies that were coming out of government were really taking into consideration what the situation was before the pandemic hit, and using that intersecting lens all along the way. And because that didn't happen, we saw so many people fall through the kind of policies and procedures that came. I'll end that.
All right.
Thanks. Let me
Great.
stop sharing.
Oh, Christine, I'm always enthralled, and I appreciate your, you know, what you have presented and the analysis that you have presented as always. It's based on extensive research. And again, you share the stories of what's actually happening there. What we're going to do now is go to the panelists who are working with organizations and interacting with people on a daily basis, to get their perspective on what they're seeing, that as a result of the policy process that you have identified, Christine. So next we're going to go to Sherry Costa, and with the Nova Scotia League for Equal Opportunities. So Sherry, welcome.
Thank you, and thank you so much to the Nova Scotia League or the Nova Scotia College of Social Workers for organizing this discussion. I think what I'd like to be able to do first, because not everyone is familiar with the UN Convention on Persons with Disabilities, so I'd like to first offer some background. So as I walk you through some of what we've experienced, you'll have a better understanding of where it is that the disability community is coming from. And I think the first thing I'd like to say is that the definition, which is often asked of us, how do you define that? And we go back to the UN Convention on the Rights of Persons with Disabilities to define it as those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. So I'll just put that out there for everyone to understand a better idea of what it is. Although there is some conversation around equal and equitable, because equal does not mean that things are equitable. So that's an entirely other conversation. I'd also like to make note that first and foremost, it's important for everyone to understand that each and every person with a disability has their own voice and lives their own experience. And the best I can do on behalf of the League is to listen to what those experiences are and to act as a conduit to move that information forward and as a catalyst to change the narrative for persons with disabilities. So I wanted to be very clear, I'm not speaking on behalf of, I'm not using their voice, I'm just bringing forward, or as was noted earlier this evening, to amplify some of the challenges.
Mm-hmm.
I think it's also important, we had reference with needing data in order to act, and it's rather interesting because Nova Scotia in particular, I don't know if everybody is aware of this, but Nova Scotia actually has the highest number of disabilities in Canada at 30% of our population, which is 10% higher than the national average. And these numbers are actually going to continue to rise as people age into a disability. And it's also important to understand that aging into a disability is not the same as somebody who has lived with a disability from an earlier age. Currently now we have accessibility legislation at both the federal and the provincial level, and these are driving forces behind some of the policies and decisions that are being done. And with this, participating and contributing to the community should become somewhat easier. And for a small percentage of persons with disabilities, this has been the case. However, for the larger percentage, as we've noted with COVID, it's actually exacerbated the challenges that persons with disabilities face. Many individuals face systemic barriers that prevent the full participation by the larger population that if you don't experience or live it, you have no way of understanding those challenges. And when we're looking at those policies, historically, the barriers through these policies have proven to be due to a number of key factors. The language that is used, I already touched on, the difference between equal and equitable, the systems that maintain inappropriate and outdated policies and practices. When the pandemic hit and there were protocols that were being implemented that were to the detriment of persons with disabilities. The interpretation of these policies by individual levels of government, by communities and organizations. But most important of all, what was really lacking with the policies was the lack of representation and consultation with first voice in the development of these practices and policies. So these were being put into place without understanding the bigger picture and how these individuals, how we would be impacted by these decisions. And we'll go back to when Canada ratified the UN Convention back in 2007, and then signed the optional protocol in 2008. And there are going to be many on this call who've only heard this for the very first time. But in doing so, this country recognized that provisions were necessary to support persons with disabilities, and that it wasn't something that is a special treatment, but it's a basic human right. So these things that we were talking about that were being denied when COVID came into effect were actually part of the rights that were being taken from persons with disabilities. And what this translates to is that persons with disabilities, when we look at the signing of those documents, we have recourse for official complaints. Not that that's going to happen, but we have recourse to be able to say, here's what's happened and here's how these rights have been violated. So if we're going to view the impact of COVID-19 and the policies through a disability lens, let's first look at when COVID-19 first presented itself in March 2020. And government was very quick to respond by implementing the Canada Emergency Act benefit and providing $2,000 with minimal eligibility requirements for everyone who was eligible for it. And that was effective immediately. This is expected actually to continue until the COVID virus, until we're through this pandemic, so for the duration of it. In comparison, for persons with disabilities, a one-time payment of $600 was to be paid sometime in the fall under the provisions that if you either were in receipt of the disability tax credit or were eligible for it, you could actually get this one-time payment. For those who aren't familiar with the disability tax credit, this is a form that must be filled in by a qualified practitioner, such as a medical doctor. They must complete this, and it's a very complicated, complex form with very few exceptions. Most doctors or practitioners who fill this in charge a fee for it. And once it is submitted, once you pay this fee, there is no guarantee that at the federal level, it's going to be accepted. So we're asking those who are the most vulnerable, who've already lost services and support workers during the course of this pandemic, to find somewhere in their coffers to come up with money to find a practitioner who may be able to fill out a form for you by a September 25th deadline that you might be able to be eligible for a one-time payment of $600. So that's just the one case scenario. Two, because of reduced services, we looked at family and friends who actually had to step in or did step in for persons with disabilities because of the loss of services, because sorry about that, I lost my speaker. Because without notice or with very little notice, Services such as home care were canceled very short notice, or they just didn't show up at all. And part of this is the policies around the home care service. Because it's privatized, these policies vary from one home care service to another, from one level of government to another. And the end result of this is that it has a significant impact on the quality of life and the health of those who need those services. I don't even know where to begin with long-term institutions. I mean, we are all, no one needs me to go into it at this point in time. It's something that should never have happened, but that at the beginning, when the protocols were first being implemented, the disability community said, this is not a good idea. You do not have the resources within, you don't have the medical resources within those institutions to be able to address should it erupt. And that's all I'm going to say for that. Most of the communications that were being done and continue to be done for the COVID are through meetings such as this, that we're using internet more, we're using phones more. It's becoming part of regular business. But if you are someone who is living in poverty, if you're a person on a disability who is living in poverty as well, or if you're in a rural area in Nova Scotia, or sometimes not even in rural Nova Scotia, you're just in the circumstances where you cannot afford the internet access, you're not getting that information. And it's not being made available in accessible formats, or perhaps even in plain language or a larger font. When we're talking about that social distancing and isolation, or that being able to move freely within an environment, but if you're blind or you're low vision, there presents some real challenges to that. I know that when we're looking at how we can move through this, what we need to do beyond what we are doing to address it. And I know much of what I'm talking about here comes as no surprise now to so many, not only within the community, but within government, who we have had repeated meetings with, who are working diligently to address some of the concerns, to ensure that those concerns will not repeat themselves. But beyond this, we need to move from consultation to collaboration in the policies and the processes that impact first voice, because it's first voice that knows and understands what those needs are. Mm-hmm. And I go back to a colleague of mine who, very distinguished, well-respected gentleman, and he put it very succinctly, that puts it in a way that resonates. And he put it as, why we are floundering today is not only because of the failure of what is called the medical model, wherever that may be defined, but also because of the failure of the social model, the failure of the political model, the administrative model, the vocational model, the education learning models, as well as our leadership model. All of these models have continued to fail persons with disabilities. And I have to go back to, we need to move from consultation to collaboration. That first voice needs to be there. Otherwise, we will continue to be impacted by the disproportionate numbers. And that's why they're currently not being measured to any amount of success. Thank you.
Thank you. Thank you so much, Sherry. I'm shocked at some of the experiences that you've been talking about. Not that I should be, but just not listening to people, not including people, is a huge issue, and which is why we are looking at how to build a more inclusive society where this doesn't happen. It's unconscionable that you come out with policies and you don't talk to the people who are going to be directly affected by this. I'm going to move on now to our next panelist. Afolake is a clinical social worker and experience in community development and working with immigrants and other marginalized groups. And she's now going to sort of explain some of the experiences that she's had working with these groups and what how the policies are affecting new immigrants and people of African descent. Alex, I presume we're switching over here?
Yep, it's coming.
Thank
Okay.
you, Colleen. Good evening, everyone, and thank you to the organizers for the opportunity to participate on this distinguished panel. It's a great honor to be here. Just in regards to the recent immigrants or temporary foreign workers, international students. First of all, I would like to say that COVID-19 has affected all segments of society. But I think part of what we've seen across Canada is how COVID-19 has shed light on existing inequalities and really exacerbated some of the vulnerabilities of marginalized groups, such as, recent immigrants, refugees, temporary residents, or, temporary foreign workers or international students. Even Kristen was able to show us the poverty rates in Nova Scotia, and even when differences in immigration status and other things were considered, it still was quite significant in terms of the poverty rates amongst immigrants. It was 39.1% when the Nova Scotia average is 17.2. So that's actually really, really concerning. Newcomers and refugees and immigrants face unique challenges, and these are they're very, very disproportionate burdens of social and economic impact on these groups of people. Just based on my work with immigrant population or people within immigrants within Nova Scotia, we see that there's a overrepresentation on the front line, high numbers of newcomers, immigrants, refugees that are employed on the front line as essential workers doing continuing care work in nursing homes, food and meat processing plants, warehouses, grocery stores, where they're coming into contact with COVID positive patients on a regular basis and at an increased risk of COVID-19 exposure. We saw that and are still seeing that they're the most exposed and least able to really exercise their rights or access adequate personal protective equipment because they don't have the sophistication to be able to advocate for themselves sometimes. And sometimes due to language barriers, they may not really be able to speak up for themselves. Through my community involvement as well, there were instances where during COVID-19, newcomer parents that work as continuing care assistants in nursing homes had to, in order to protect their loved ones, they had to change the rhythm of their lives by making decisions to sleep away from their families by staying in a hotel and performing meticulous cleansing rituals to protect family members and not being able to embrace their small children and carrying a tremendous amount of fear, stress, and guilt. And I can say that the toll from all that experience still remains with a lot of people.
Wow.
In regards to temporary residents, work permit holders, international students, the other issue is the risk of losing status for immigrants in this group or this category due to COVID-19 related delays in immigration applications and leading to the possibility of some people not being able to work and maintain and keep their status. This extra vulnerability, we've seen that even with a certain man. There was a CBC story on the case of a dual Turkish-Dutch citizen, Murat van de Born, who he's now facing an uncertain future because of COVID-related delays in his immigration application. He first came to Halifax in 2011 to study at St. Mary's on a student visa, and he's been working on a full-time contract providing IT support to the NSHA. He applied for his permanent residency, permanent resident papers in May, but he couldn't get a medical appointment with his doctor because of COVID, and his English language test was going to expire in June. So he decided to submit his language certificate anyways, and in June, he was informed by that his PR application was canceled because he submitted an expired medical certificate, and his work permit was canceled with only one option: to start the whole permanent resident application from scratch. He has only 1 month left now to get his immigration status sorted out, or risk losing his job as an IT person at the NSHA. And for him, in terms of the processing of his application, it would take at least 6 months until a decision can be made regarding his status. So until then, someone like Murad van der Born is here. He's as a visitor, and he's not going to be able to work. So a lot of situations like this where people fall out of status and sometimes some people have no funds to even renew their permit or apply for a new permit. So while they're in the waiting, they're waiting for Citizenship Canada to make a decision. They're not eligible to work. They're not eligible to apply for income assistance. They don't qualify for the emergency relief fund. And so, it's a very, very distressful place to be, as you can imagine.
Wow.
In regards to international students, the severe impact of the pandemic on them has also been widely discussed. The temporary status of international students has worsened based on the precarious situation that, in terms of they only can work a limited number of hours is what they're allowed to work. And with the hours that they're working, that doesn't make them to be eligible for COVID emergency benefits. So during the lockdown, a lot of the international students that we were in contact with were restricted to their resident buildings and were not able to work. This extra vulnerability just created a feeling of isolation and increased financial strain for this group of immigrants. Also, due to the travel restrictions, newcomers and immigrants were not able to fly home to visit their families. A few people in the community also lost their parents or family members during COVID, but they were unable to go home to grieve and memorialize this loss with their family in ways that are religiously and culturally appropriate. And that led to, and I would say is still leading to feelings of sadness, helplessness, and further distress, or what I would call complicated grief for a lot of recent immigrants or immigrants. There's also the issue of stigma, racism, or xenophobia due to COVID-19. Although I'm not sure, if there were specific examples in Nova Scotia, but during the pandemic, there were a few disturbing stories of Asian Canadians that were targeted and harassed because of racist perceptions about who they were, and who they are, and where they come from. Media reports suggest that Chinese and other Asians around the world have been victims of stigma since the beginning of the COVID-19 outbreak. And this situation was made even worse by the US president's deliberate insistence to give coronavirus an ethnic and geographic association. It is notable that this violence has been directed at people of Asian descent, even though the disease has been spread by travelers of many different ethnicities. And this reflects the easy association of otherness of the kind that shaped foundational exclusionary immigration laws and regulations, and that apparently continue to continue even to this present day. So in terms of what we can do, my suggestion is to ensure that public health responses to COVID-19 are inclusive and respectful of the rights of marginalized groups, including newcomers, immigrant, refugees, and other racialized groups. Infusing the anti-oppressive perspectives or anti-oppressive lens or framework into applying a diversity lens when we, investigate the negative impact of COVID, considering diversity and inclusion when making any decisions around staffing, policies, programs, services, and practices. I think it would also be good to adopt a pluralistic or intersectional vision to think about immigration in the after the pandemic, or should I say the post-pandemic world. A pluralistic vision of immigration based on plurality ways of thinking will combine a top-down approach of immigration policies with consultations among resettlement organizations, immigrants themselves, and refugees. Listening to their voices and giving them the opportunity to tell their stories and have a say in how we're going to be able to resolve this issue. This will also allow policymakers and civil society to consider newcomers' social integration into Canada beyond how sometimes immigrants are viewed or considered as just economic benefit to the country. It will allow addressing immigrants and refugees' specific concerns around social ties, social risk, stigma, and socioeconomic impact during the pandemic. I also like the idea, based on what Monika had shared, about implementing a social determinants of health framework to understand the differential impact of the pandemic on different groups of people. Mm-hmm. To support access to basic income for everyone, not only, during the pandemic, I believe that the government had given a boost to I believe the money that's given to families, allowance, like the children allowance, but I'm not sure if that's still, happening, but that was actually really helpful for a lot of families who, again, were working on the front line and earning, not earning a lot of money. It would also be helpful for the government and policymakers to invest in affordable housing and have plans for accessible and flexible employment opportunities for all people, regardless of who they are. Having an accessible and culturally appropriate mental health services for people who, didn't have social capital or no supporting network to rely on in the event of crisis, I think is also really important, especially for recent immigrants who don't have families here and don't really have people to rely on, dependable people that they can call on. There's also the issue of loss of remittances to families back in their home country. People, because of issues around like job loss, that some immigrants or recent immigrants experience due to their precarious employment. Part of what a lot of immigrants do is, no matter what meager salary or what little income they're making, that they always remit money home to their parents and their families back home because of the loss of jobs and not having and having a hard time finding a job. This was something that a lot of immigrant families were not able to do, and it's created a lot of stress for a lot of people based on what we're hearing. My other suggestion is for their people to be open to working with faith-based organizations, such as the mosque or the churches, and recognize that support will work. That working with immigrant population would require that we be willing to tweak things and not be afraid to work with faith groups, because a lot of immigrants or newcomers are people of faith, and you find that they either go to church or they go to mosque, and when they're in crisis, oftentimes this is where they turn to. So working with faith-based organization, I think it's going to be really important. And public education and communications in regards to the virus and how the disease is transmitted is also, I believe, should continue to happen and is critical in realizing the right to health and combating the stigma of coronavirus. And lastly, I think it's important to look at using anti-oppressive principles. How do we dismantle the fundamental source of the systemic forms of racism and lack of access that fundamentally lead to the pattern of recent immigrants and refugees and temporary foreign workers and international students being overrepresented in essential jobs and not able to access the kind of jobs that allow some of them to also be able to stay home and work from home or self-isolate during COVID. We should really ask ourselves why brown and Black bodies are overrepresented in this kind of jobs.
Thank you. Thank you very much, Afolake. That was very enlightening and helpful, and really shows the difference between the various groups of newcomers to our province, the various groups, and how the various policies are interacting them. A theme is coming out here is lack of voice, lack of inclusion in people, contributing to the policies that are being implemented that have such a direct impact. And we heard that with Sherry and as well with you. We're going to move on now to our last panelist, and Christine Basque is a Mi'kmaq social worker with Eskasoni First Nations, and she is born and raised there, and she's the supervisor of the Wigamanage Gigmagetnak family group conferencing program there. So Kristen, we look forward to hearing from you.
Thank you. I'd like to thank Alec for inviting me to be part of this panel, and oh my gosh, what a difficult job it'll be following all these wonderful ladies and all these very great things to hear. And as they were speaking, I was thinking, oh my God, that's how it impacts our community. So tonight I'm just going to speak about my community of Eskasoni and how COVID has impacted us in our community, and a lot of the stories and a lot of the information shared. I think everyone similarly has been impacted. I just wanted to talk about, and my apologies, I'm sitting in my car waiting for my son to be finished his tryout. So if there's some bustling in the background, he's probably getting in the vehicle. So I just want to talk about my community of Eskasoni, and not only my community, but my culture, and how in times of need or in times of stress or happiness, celebration, sadness, how we respond. And oftentimes we respond by helping one another and coming together and celebrating our successes and going through the journey of sadness together. However, with COVID, the way it is, it has, as information has shared, we have to self-isolate. We have to move away from everything we know. We had to move away from, because we come together, like just as my program, Wigamanage Gigmana, is family group conferencing, but in essence, what it translates into is we're calling on our families, calling on us to come together in time of need to help one another. So with COVID, we're being told the exact opposite: self-isolate, stay away from people, 6 feet apart, all of those things. So it has greatly impacted my community. And when COVID, when we were very in the beginning stages of it, we were a community that went on lockdown. Our chief really recognized this in saying that we don't know how to self-isolate. We don't know how to social distance. because we're very social beings and we're very social people as Mi'kmaq. I think about my mom's, like every single day we all go. Oh, my brother goes and his kids go and everybody goes. And then like just yesterday, my grandmother turned 85 years old. And coming from a big family, everybody was coming together, and we're like, part of us is like, oh my God, we're supposed to social distance, but we really don't know how. So I commend our chief, Leroy, for, as it was a very difficult decision, because we have a lot of people, a part of our community that don't live in our community, that we had to put up the barriers, we had to put up the blockades, because our populations are very vulnerable populations, as everyone has mentioned in their speeches around. We have a high number of people diabetic and heart disease and a lot of autoimmune, and a lot of people, I mean, when you Google it up, I mean, we're told there's 75% of child poverty in my community. But if you're knee deep in it, you don't know, because you don't know you're in poverty. You're just living your life. You're just living as my daughter would say, living her best life. And she doesn't know any different, because this is what we have, and this is what we live, and we support one another. So then when we started the lockdown, and then we had a community lockdown every person had to be indoors at 6 p.m. and nobody could visit one another, which then, if you have people that are already feeling self-isolated without the self-isolation, that's really hard on people's mental health. And and then you put poverty into the mix, and people stocking up on toilet paper and stocking up on Lysol wipes, that's a luxury. If you're living on social assistance, barely making enough money to feed your family, how are you going to be able to stock up on toilet paper or even Lysol wipes or anything else? And then we have the school, like the education. We're very fortunate to have schools in my community of Eskasoni. We have a Mi'kmaq immersion school. We have K to grade 12 in our community. So we're very fortunate that way. But when we're on lockdown, and then we do have the luxury of technology, but not everybody can afford. If you're living in poverty, not everybody can afford Wi-Fi and internet, or even have access to tablets, to even have online learning. So that also posed a very big challenge in my community. I mean, even still, when we're looking at what it looks like today, our students in Eskasoni only go 2 days a week. So that has impacted when you have education, and you're trying to provide an education that will be at par with the rest of the province. And a lot of parents are on kind of on the fence around that, and saying like, oh my God, my kids are only getting 2 days of education. They're not gonna, how could they learn? How could they do this? But then what other choices do they have? Because then you're looking at, okay, what other schools are we gonna send them to? That means you're sending them off the community. Then who's gonna drive them? Who's gonna take them? You have a choice, but not a whole lot of choice. And then you get into some of the relief funds that were put in place. You have the CERB money that everybody's talking about. And then when you're already living in poverty, and you see this opportunity, and you meet with the criteria, and you don't really understand what that whole program is about, other than like, oh yeah, you apply, you call this place, you're going to give you some money. And so people are calling and getting served, and at the end of the day, not realizing what type of impact that's going to be on the long run. Because now we have individuals who had applied for CERB, but were also on social assistance, and now are having to pay back that money, and which, like somebody, one of the panelists had said, are now in greater poverty than they were even to begin with. So it's like a forever trying to get out of that slump. But we were very fortunate because our chief and council had tried to accommodate everybody, because we do have a grocery store in our community. We have a health center that has 2 physicians. So they would come in, and they quickly adapted to do online, not in-person visits, but they could do online visits, which was really good, because sometimes, because we're looking at 2 doctors and 4,500 patients, because my community is a population of 4,500. So you can imagine when you have 2 doctors trying to do what they can do, and you have everybody freaking out about COVID, saying like, oh my, because at that time, especially in the beginning, we didn't even have a clue on like as we learn more about it now, we have more knowledge, but back then we're like, oh my God. So the phone lines at the health centers were going off the hook. So like, we also have our elder population. Our elders are highly, highly regarded in my community. And we needed to do everything we could to protect them. But at the same time, being told, no, we can't visit them, we can't see them. And everybody's being fearful about, okay, I can't go see my grandmother because, oh my God, what if I have COVID? I don't want to give it to her. But in my community, we have been very, very fortunate not to have any cases of COVID. And I think living in Nova Scotia, period, we're very fortunate to have such low numbers. The other part is like when we shut down our community, we're so interconnected with all Mi'kmaq people. Even though I'm from Eskasoni, I have relatives in all 13 First Nations across Nova Scotia. And in fact, my nephew, his mother is from Membertou, and his father is my brother from Eskasoni. So when we had lockdown, he spends most of his time with my brother, but then he couldn't even see his mom. So then that was really difficult, and he was not the only one in those situations. The other piece of it was around, the isolation itself was really hard. But when in my community, when somebody had mentioned also about death and dying. So when it was such a hard time, as everyone knows, everybody felt it around COVID and losing a loved one. In my community, when we have a death in the community, that's not just for that immediate family. That is felt in the whole entire community, in the whole Mi'kmaq nation. And for us, we have wakes in our homes, and we have a 2-day wake in our home. And then people from New Brunswick, Quebec, Nova Scotia come and pay respects to the family. And also then we have our funerals, which are very large. And after our funeral, we have a special auction called the Afolake, where people bring their most prized possessions to be auctioned off. And just for example, a case of Diet Pepsi could go for $300 in our community,
Yeah.
because we believe that it's going to a good cause. So at the end of the Solite, whatever is raised at that Solite is given to the family, so that they aren't burdened with the cost of the funeral, because we all have a responsibility to help one another and share that.
Mm.
And so during COVID, we weren't able to do that. We weren't able to come together and put on the solides and support our families. And when somebody dies in my community, everybody starts cooking and bringing food and bringing like never ending food to the family. And so now, like when we're, I say knee deep in COVID, we weren't even allowed to go and pray, and pay our respects. But one way, because I truly believe Mi'kmaq are resilient and creative and will always find a way to do something, even though we weren't allowed to pay our respects. If someone had passed in my community, we deal with TW Curry. So TW Curry would drive through the community, and everybody would come out at the end of their driveway just to pay respect to the loved one and the family. The family would be driving by in their car and just say thank you to everybody. And that was our way of showing our respect to them. And then when it came down to helping them off cost to set up the funeral, because of the wonderful world we live in terms of technology, we pulled together a online auction that would raise the same amount of money and then some, so that they have enough money to pay for the headstone and not have to worry. So in many respects, it was very hard, but we always find ways to rise above and be resilient.
Mhm.
And I know even right now there's a lot of turmoil and a lot of mistrust that, you know, my community and my people may have, and very disheartening. But at the same time, you know, with all of the stuff that was happening in Digby, what was going on, I mean, like the situation that happened in the hospital in Quebec, and that went, I mean, that was so heartbreaking. And but the sad part is, there's even the red tape movement. I mean, my son plays hockey, so red tape movement around, you know, saying that we won't stand for racism in hockey. But the sad part is, even my son at 4 years old, when he first started to play, he's 9 now, but when he first started to play, I had to talk to him about not everybody's going to be so nice because of the color of your skin. And at 4 years old, and playing tot hockey was his first experience with racism. And every year since then, he's played. Every year we have an incident. And all I could tell him is, you know, you keep your head up, be proud of who you are. And both my children are fluent in Mi'kmaq, and I really push them hard. I push them hard to be proud of who they are. So because, and I tell them, resiliency runs in your veins. You feel that in your blood. You know, I'm all on blood memory. I said, you come from a long line of people that are strong and have overcome so many different things. So I guess that's the thing that I want to pass on to people, is that, you know, despite how difficult and how hard COVID has been on everybody, I mean, there's ways that we could continue to support one another. We we can build on those relationships of reconciliation. And like somebody said, we are all treaty people. So
Kirsten,
that's all I got.
Kirsten, you have really showed us this evening how resilient the Mi'kmaq people are in the stories that you have shared this evening, and how the different policies affect the community. And obviously mental health is a huge part, how it has affected people and how it has impacted on your cultural beliefs and traditions. And as it has everyone, but there's uniqueness in your community. So thank you for that. I'm just looking at our time, and we wanted to have time here for a few things, some questions from the participants. And what has come out, I'm not sure how much of a discussion we're going to get into the underlying reasons why we're seeing what we're seeing, why the policies are the way they are, why there's so much social exclusion, which has come out of many of these presentations, all of these presentations. So Alex, can you identify a couple of a few of the questions generally that has come up, and then hopefully we'll get a chance to just identify a little bit more some of the strategies we might look at?
Yeah, so the first question comes around access to healthcare during COVID, and particularly the availability of family doctors. And the question is, moving forward, what do you think we should do to make sure that communities have access to health services without having to travel outside one's own province or waiting for a doctor to come to your community? And I would hope that we could talk a little bit about mental health as part of healthcare as well.
Are you addressing that to someone in particular?
That came from participants. I probably would be a good idea to start with Monika and see where it goes from there.
Yeah,
Okay.
really nodding. Yeah, I'd sort of write something in the chat box. I think that's a huge question and could be, you know, a whole discussion of healthcare planning. The one part I did comment on, and I think was mentioned by Kristen also, is the use of virtual care, which has, you know, quite changed how I practice my family medicine, and how many family doctors in particular and many others have been providing care to be able to, you know, have changes that were taking forever to put in place be suddenly put in place within, you know, a month, to be able to do phone visits and have them officially count. That was the whole part of the problem, is that they wouldn't count as visits if you did phone calls or, you know, a video call. But then all of a sudden we were able to put that into a place. So that's one piece of it that I think that has significantly increased access. It's not always the best way to deliver care, but it can be incredibly useful. Some of the challenges that I have found is that many people don't have phones or don't have, you know, plans, and it's often quite hard to get a hold of people. So that's one gap. There's a lot of for-profit virtual care companies that have popped up that kind of get around kind of gray areas in provincial legislation, and so that's only accessible to people who can afford to pay the, you know, membership to access a nurse practitioner or a physician. So there's a lot of issues also. It doesn't necessarily solve the fact that people might not have a family doctor. And I know, you know, Cape Breton and across the province, that's a significant issue. So I think there's many other aspects to that, including the fact that ideally we want people to be healthy in the first place and not need to have to access that care as much as they need to. And I think, you know, mental health has been an ongoing issue. I don't have a particular solution for that. It's, you know, very long wait times often, especially if it's not kind of a crisis right at that moment. And, you know, we should be able to provide care long before that. So I don't have a particular solution to that. My focus has been mainly the primary care side of things. So maybe others have comments from their experiences.
I would just add some of that, Monika, is the concept of health has been reduced to, you know, the absence of disease. Physical disease and mental health has been excluded in many ways, as it was from the universal healthcare system that we put in place early on. And we are now still seeing the results of that narrow vision of health. And I think COVID has really, really exposed, in my experience, the stress on mental health is huge. And we've heard that from our panelists as well, describing some of the people that they're working with. Alex?
I know.
Yeah,
Oh, sorry.
go ahead, Kirsten.
I just wanted to say, like in my community during COVID, and to help people because everybody was under extreme stress. There was a lot of focus on our smudging and going back to using those medicines, and also utilizing the medicine wheel, and to help people cope, when we call it coping with COVID, in balancing their medicine wheel and things they could do to help in their mental health, so that that medicine wheel would be balanced physically, emotionally, spiritually, and so that all of that would be so that was really, there was a big resurgence of like people wanting to, because there was they wanted more of the cedar and the sweetgrass and the sage and tobacco as medicines.
Right. Which is great in the sense that people are going back to their traditions and using that as a way to get through very difficult situations. Okay. Again, looking at the clock, Alex, do we have another question we might cover?
Yeah,
Before
I think this.
Can I just say something?
Yes, please go for it.
As much as the virtual care, is better than not having anything. I know that people in my community that have been haven't always found going to the doctor to be the best experience, sometimes for cultural reasons and due to sometimes language barriers and just cultural differences, are having a hard time with the virtual care. Some people are just not going and getting any care, period, at this time, which is really unfortunate, because what it means is that things may be coming down, that would probably not be good for people's health. But for right now, there's a lot that people are experiencing in terms of their physical health and even mental health, that they're not really, seeking the right medical care because of the having to go and meet with their physician virtually instead of in person. So people are, sometimes when they're at the ends of their rope, they end up at the emergency, and so there are multiple emergency hospital visits. So just something to mention.
All right. Very
I'll say, although it doesn't get to everything you've said, when people are now given the option between virtual or in person, almost everybody is choosing in person. So it's almost back to where we were, because that's what people in the end prefer.
Yeah.
Can I jump in and just speak to that point about that virtual, because, and I know I touched on this a little earlier, but many services that are now being delivered through phone and video meetings, not everybody has access to that. And I'm thinking one of the things that has to happen is the internet has to be viewed as an essential service. We have far too many people who are living in rural areas or within poverty who cannot afford these means of technologies or accessing something as essential as internet. But the reality is it's here to stay. And unless everybody has universal access, they're not going to get the care that's needed.
Mm-hmm. Very good. Thank you very much, Sherry. Appreciate that. Good point.
Okay, so there's one more question that is going to take way longer than the remaining time that we have to dive into. but I think it's probably a good question that Christine can start us off with and see how far we can get. But the question really is asking about the climate crisis, its impact on COVID, and how that has how that's impacted poverty and how people experience poverty in Nova Scotia even more. So I know I'm putting you on the spot, Christine, with 8 minutes to unpack all of that, but maybe you could get us started.
Yeah, sure. Actually, I mean, it's great because in terms of the solutions, I'm going to plug our social policy framework. So one of the things that we did publish in the last few months, actually on the date that the pandemic was declared, not on purpose, we published a social policy framework for Nova Scotia, which really lays out the principles by which we can build good social policy for the province. And that includes policy that's intersectional, that's evidence-based. So all the things that we're talking about tonight, that we decolonize, that we ensure that we deal with climate justice. So the actual kind of what I was thinking about as I was constructing this is we have some possibilities here. And as Colleen said, and we opened, you know, we do not want to go back to normal. The climate crisis was very much is here, and we need to act, and we need to do it in a climate justice framework. And that brings together all of the things that we're talking about. We need to ensure that as we move forward and think about the recovery, that we build the green economy, that we actually invest in the things that are already green. So that's childcare, that's education, that we build in things that will build our community, that's arts and culture and recreation and community development, that we actually take the opportunity to shift to renewables, that we make sure that those who have largely not been to blame for the climate emergency, but who have been facing more of the burden of the climate emergency itself, whether that's from not having, you know, it affecting their housing and not being able to repair it, all of the impacts that we see in our own province, never mind across the world, means that we ensure that our policies are written in a way that those who haven't been largely to blame actually really do benefit from those policies. And that's, I think, one of the main messages I took away from kind of looking at the research about why we so desperately need a new social policy framework, which really laid out income inequality, the erosion of democracy, which is what we're hearing about tonight, right? That like our elected officials are not listening to the people who really have the expertise to make that, to make sure that the policy that's being developed really responds to the needs in our community. But that if we actually develop policy that meets the needs of the most marginalized, that will actually meet the needs of the most privileged. But if we do the opposite, chances are many people will fall through that safety net, right? You know, what disheartened me about, and I'll end here, is that we kind of went back to the individual focused health messages again, right? Putting the weight of responsibilities back on individuals and families. It made me think of the old list of, like, you know, lifestyle choices: eat healthy, manage your stress. I mean, wear your mask, wash your hands, decontextualizing what it means to actually be healthy as a community and what it takes for somebody to be able to choose health, their own health over income, not having to make that choice, right? And so I think that's where we connect the dots and say, we have a real opportunity here to shift in a major way, and we have to. The climate emergency makes us have to do that. The pandemic has showed us that we actually can and must do things differently, and we can do that. You know, we've seen governments make policy changes on a dime. The problem is they aren't doing it and listening to the wealth of expertise and evidence that we heard here tonight. So I will end there.
So Christine, I think you did a fabulous job of taking us through this to the end, given our timing that we have left here. But as you said, we have to change the way we look at things. We have to take this opportunity. A crisis is an opportunity that we shouldn't let go by. And this is the time that we can make changes. We didn't get into all of the different strategies of change some of you have talked about and alluded to, and that's a much bigger discussion. But what keeps coming back to me is the underlying values and attitudes that people carry. Everybody that spoke tonight talked about being the excluded from the decision making, from the policy making. There's historic and current racism and oppression that excludes people. So if we're going to bring about changes, it has to include people. It has to include, as you said, the wealth of knowledge and experience that we have shared here tonight. So there's going to be many strategies that need to be looked at and to bring about change, but we have to look at the values, and the values of people. Everybody is of value. And I think a lot of our problem is we look at like we're living in an economy where our value is dependent on what we contribute to the economy, rather than living in a society where we value people for who they are and what they have. So people with disabilities have so much to give to our society. Elderly people have so much, young children, people, new immigrants, but we only value them according to what they give to our economy. So if we can start changing that, that might help us start to change some of these policies and really get at inclusion. That was the big message that came tonight from me, or that I've heard tonight. This has been fabulous. I really appreciate everything that you have contributed, each one of you. And to the participants who have sent in the questions, certainly appreciate that. We had hoped that we would have more discussion and more input from our participants. But I think this is our first kick at the can here of uncovering and looking at beyond recovery. How can we build an inclusive society? And we have more coming up in the future. So I think I just have to say thank you again for getting us started on this. Alex, do you have any messages or words to say, as we have 1 minute left before we are?
No, folks have asked about the slides from tonight, and we will email that with the video that was recorded tonight out at some point in the next couple of days, and we'll also post it to our website. So thanks everyone for joining us.
Oh, big time, thank you.
Thank you, Colleen. Thanks, everyone.
All right, thanks. It's been great.
Yes.
It's nice to meet you, and I hope to get to know you all a bit more that I've heard so much about, and now I've met. So
same here, Colleen. Thank you for making the process so much easier than I thought it would be. So, and reaching out and just connecting before this event, it made a huge difference in helping to calm the nerves. So, yeah, much appreciated. Yeah. And it's great, being on the same, on the panel with Kristen and Monika and I believe Sherry. Yeah. So, and Alec, thanks for being the IT guy behind the scenes doing the work, the tech support.
Great.
Yeah.
No problem.
Thank you, everyone. Yeah.
Take care.
Thanks, everyone.
All right.
Thank you.
Good night.
Night.